I'm going to speak today about designing gender responsive digital health, making digital health work for women. So, the majority of my research explores how gender as a social relation and how it intersects with other social stratifiers to influence sort of different health systems components. So not only sort of access and utilization to health systems, but thinking about health workers as well, governance structures. And today I'm going to be really focusing on digital health in the context of health and health systems. So first, why is gender important for digital health? Well, digital health, like most things in life, is not neutral. Social structures influence who has access to it, who benefits from it, who can utilize it, gender norms, roles, and relations. So, how men and women interact. So, also gender norms of what's acceptable for women and girls, for example. These shape access to technology, digital literacy, privacy, and trust, which are all important components in relation to digital health. We know that women often face barriers in regards to digital health, such as limited mobile phone ownership, limited decision-making power about utilization of phones, for example, different privacy constraints, cultural norms restricting technology use. And then we also know that women's exclusion from digital health research can exacerbate the global gender data gap. And what I mean by that is when women are excluded from digital health or digital health research due to many of the barriers on the slide here, then we lack key data points about women, our women's inclusion in data, and that contributes to what is called the global gender data gap. And that digital health itself, we know, can also reinforce or transform existing inequalities depending on how we structure digital health, how we design it. And if we do not consider gender and gender inequities within our digital health interventions, we really risk widening existing health inequities. So this slide here is taken from the Mobile Gender Gap Report, the most recent one in 2025. I'm not going to go over all the data points here, but what I really wanted to highlight is that mobile phone ownership, mobile phone utilization is much lower for women, particularly in low and middle income countries. As you can see on the top left, 63% of women now use mobile internet which is actually slowed over the last year. You can see that women are 14% less likely than men to use mobile internet. This means totally that there's 235 million fewer women than men who use the mobile internet. So these data points really just show and really bring home the notion that really do have a gender data gap, a gender mobile phone gap, which has impact for digital health and also impacts our digital health research. Some additional gendered realities that shape digital health access and engagement, and this is across low, middle, and high income countries, include things such as privacy and safety. We know that women face higher risks of online harassment and surveillance, and sometimes that surveillance is by their own partners in the home. Care burden, women's unpaid caregiving responsibilities affect how or when they're able to use digital health. Overall representation within digital health, the existing data gaps, algorithms reflecting male-centric health models, for example, leading to diagnostic and treatment biases. So that is even in the data that is collected from digital health platforms, how it can bias our diagnostics and treatment basis if we don't include a gender responsive lens. And then, of course, intersectionality, which is the notion that gender does not operate on its own. it intersects with other stratifiers such as race, class, geography to shape digital health access and outcomes. So not all women's experiences are going to have digital health and inclusion in digital health research, for example, is going to be the same due to these intersecting social stratifiers. So what is gender responsive digital health? It's an approach that ensures our technologies are designed and implemented in ways that recognize and address gender-based differences in health needs, access, and experiences. So not just between women and men, but also among women. So women of different socioeconomic status, women from different racial and ethnic groups, education groups, for example. Key principles in gender responsive digital health include equity and access, ensuring that women and men can equally access and benefit from digital health tools, tailored design, making sure that we're adapting our technologies to reflect gender specific health concerns. That's often can be related specifically to women's health. It could be related to reproductive health, menopause, for example. And then also empowerment through information, ensuring that we're providing personalized, culturally sensitive health information that supports informed decision making. And then lastly, inclusive data practices, making sure that we're collecting and utilizing sex and gender disaggregated data to help improve our health outcomes and reduce algorithms. So that means not only collecting data from men and women and disaggregating that data, it also means that we're asking gender sensitive questions that might only be or gender specific questions that might only be relevant for one gender group, such as women and girls or men and boys. Some examples of gender responsive digital health. We have apps designed with low literacy features such as audio prompts, visual symbols, voice-based navigation. Here we're really thinking about accessibility within our digital health. Telehealth platforms with private and safe consultation spaces, anonymous logins, for example, discrete notification settings to protect users from domestic scrutiny or community stigma. This because privacy and safety are huge components when we're thinking about gender responsive digital health. Inclusion of women in the design and testing phases, so community engagement here, thinking about co-creation workshops, for example, feedback loops, and then also policies ensuring affordability and equitable access. So that might be subsidized data plans, free access to essential apps, community-based digital literacy. So these are just some examples of what gender responsive digital health might look like. So with that, I want to focus now on a study that we did in Mozambique, where we looked at women's participation in mobile phone surveys specifically. And we published this paper recently, just a few months ago. This was a partnership with INS in Mozambique. It was part of the larger rapid mortality mobile phone survey, or RAMPS for short. This was a project that tested the use of mobile phone interviews for childhood mortality measurement at the national level. We conducted a qualitative study with 32 women who had participated in the RAMPS mobile phone surveys. We conducted both in-person and phone interviews because we wanted to compare and contrast the two different modalities. And we used thematic analysis which would manually use this with a framework approach to data analysis here to really pull out key themes in the data. And you can see here on the screenshot of the front of the paper, my different co-authors and collaborators on this project. So what were some of our results? So again, we were really interested in, women's mobile phone participation and the gendered related considerations, not only in relation to their access and utilization and ability to participate in mobile phones, but also thinking about time use, thinking about safety, for example. Some of our key findings included that we found that overall our mobile phone surveys reduced time burden and women felt they were very convenient compared to in-person interviews. So this was related to when we're thinking about our data collection strategies and how much time or time use that it takes. You know, mobile phone surveys can be a really good alternative to different data collection strategies. We did find, however, there were difficulties ensuring privacy in mobile phone surveys compared to in-person interviews. We also found that the interviewer's gender affected participant responses, and the women did have some safety concerns. So I want to touch upon each of these briefly now. So firstly, the reduced time burden and convenience of participating in mobile phone interviews compared to in-person. So this was I would say, a positive finding that we found, you know, that what women overall really did find mobile phone surveys more convenient. Women often have less free time due to their caregiving household responsibilities, which mean that time-efficient research methods can be very important. As you can see here, mobile phone interviews averaged about 15 to 30 minutes compared to 30 to 45 minutes for in-person, reducing participant burden. And then many participants preferred them for their flexibility, convenience, and ability to multitask. I mean, one flip side of this is the ability to build rapport in mobile phone surveys compared to in-person interviews, that you don't have as much time to build that rapport with respondents. They did find them more convenient overall. And you can see some quotations here on the side of women just saying how much they preferred mobile phone interviews. We found, however, that there's difficulties in ensuring privacy in mobile phone surveys, and privacy is a really important topic from a gender perspective because it's tied closely to safety. Respondents, some of them really struggled to find private spaces for phone interviews. And when you're doing a phone interview, you don't have very much control over where the person is taking the interview, like in-person interviews. You can have more control. You can leave. You can find a different location. You can stop if there's interruptions. This is particularly relevant if you're including sensitive topics like family planning, intimate aspects of health. These can be harder to discuss over the phone, especially when men were nearby. And this is something that researchers don't always take into consideration, of this privacy dimension. As you can see here, what from the quotes, one participant said, "I can say it's not easy to find a private place because there are times when there are a lot of people here. You can't sit down and talk, but if you had time like now, then I'm alone, there's no problem." Or I can answer with reservations because there are things that I can't answer when I'm with someone else. And another factor here that came into play was women answering the phone on speakerphone when other people were in the room, which could really impact the responses that they gave. This is probably not a surprise to anybody, but the effect of the interviewer's gender on participant responses. So, as one would imagine, female respondents often prefer female interviewers, especially when you are dealing with more sensitive subjects, which we were in this study, especially around reproductive health, for example. We know in many contexts, cultural norms may limit women's ability to speak openly with male interviews or even interact with them, which can really affect response accuracy or data validity. You can see from the slides or the quotations on the right here, you know, women just saying that they would often prefer speaking to a woman. And then women's safety concerns was another big factor here, and other studies have found this as well. This was like two flip sides. There was a fear of scams and negative reactions from male family members when contacted by male interviewers, particularly. Some participants questioned the legitimacy of phone interviews, especially when they were conducted by men. And one woman was particularly worried about being thought out to be unfaithful if she was talking to a man on the phone. And again, other studies have found these safety concerns in place as well. Um, as you can see from the quotes again on the side, it must be a woman. Well, if it's a man, my husband might think it's a lover. Um, yes, might be more comfortable participating in a phone interview, but with doubt, not knowing if they are scammers, I prefer in person. So in conclusion, mobile phone surveys, I think, well, one, it's really important to think about these different gendered dimensions when we're thinking about digital health interventions. It's important to think about women's inclusion, the type of data that we're collecting, as well. Are we disaggregating our data by sex or gender, but are we asking the right questions as well? It's important to think about time burden as well, and really important to think about um, women's access and utilization as well. So mobile phone surveys, we found that they can be convenient and flexible for women than compared to in-person interviews, reducing time burden and allowing for multitasking. I did mention on the flip side that the ability to build rapport was a big issue for that one. Key challenges include privacy, response bias, safety, especially when you're dealing with more sensitive topics, that often women prefer female interviews for sensitive questions, and that access gaps really persist. Rural, younger, less educated women are often less likely to be reached due to phone ownership and household dynamics. The third point about women preferring female interviewers is interesting because, as many of you probably know, when you're recruiting for data collectors, especially in many of these contexts, they're often men. They're often male data collectors, especially if the data collection involves travel. Men often have more flexibility. So it can actually take a lot more time and effort to locate and identify women, but then also train them because they might not have experience in being data collectors. So there is an additional effort that often has to get put in place if we do want to have female interviewers. So how can we improve women's participation in mobile phone surveys? And this is really coming out from our own study. The using mixed methods sampling approaches are really could be really useful. Many mobile phone surveys, and this was included in the original RAMP survey, they use random sampling. But what we can find is that you might exclude a large portion of a population if you do that, particularly those that are more vulnerable or marginalized. And in this case, women who don't have access to a phone or don't own a phone. And we saw that the gender data gap and mobile phone ownership is quite large. So we can combine these random sampling with referrals and callbacks to reach more women, especially those who are younger, poorer, or in low areas of connectivity. So we combine, we really want to sort of reach these more marginalized groups, and we really need to think about the equity within our sampling methods. Very important to ensure privacy, that we're conducting interviews in private settings. There are systems and structures you can put in place. Try making sure you're avoiding speakerphone, asking participants to not be on speakerphone, allow respondents to pause or stop interviews if privacy is compromised. In some cases, you can have like a safe word that a respondent can use if they're no longer in a private situation, or allowing them to just like disconnect if they feel that their safety is compromised. We really thinking about how we can reduce not only response bias to improve the validity of our findings, but also potential harm for our respondents, particularly when we're thinking about asking about sensitive topics. Adapting our questions. Sometimes a mobile phone interview is not going to be appropriate if you're asking highly personal or say sensitive questions. especially if you cannot guarantee privacy. So in some cases, you might choose to skip those modules or questions or just not include them. And then establishing credibility. I mean, this is important in all research, but with mobile phones, you have this added dimension of potential participants being worried that it's a scam. So really explaining steady protocols at the start to reduce concerns and also to help build rapport, because as we know, that can be more difficult with a mobile phone survey. And with that, I just want to thank our team in Mozambique at INS here, our team at Johns Hopkins University, and the funder for this project, which was the Gates Foundation.